First, we're going to talk about pain itself as a concept. I think it's very important to understand what pain really is, and so we can appreciate how to talk with our runners, or if you're a runner yourself, how to understand it. And then we'll talk about the stages of healing when you are injured. And lastly, when to run with pain. So I do want to give kudos to Dr. Lomir Mosley. He is a physical therapist out of Australia. He wrote a book called Explain Pain along with David Butler, and they really led the field about pain science and what it really means. So let's start with this. I had a patient a few weeks ago before Boston. He said, hey, I am running and now I have knee and shin pain and I don't want to stop running because I have Boston in 6 weeks. So should I keep running or what should I do? And he said, don't say stop running, because as we know as runners, they don't want to stop running. So luckily he reached out to me, and I'll tell you what we did for him at the end. But before we answer this question, we really have to understand again the concept of pain. So for example, when we don't have pain, it sounds like a wonderful thing because you don't feel pain, and who doesn't want that? But it's actually not a great thing. It can be fatal. There are some people out there that have this condition called congenital insensitivity to pain, where they don't feel pain at all. But the issue is people may not be aware of an infection or some issue going on with their skin, for example. If they're touching a hot stove, they won't feel it. And so that could cause a lot of harm. So with that notion, pain's reason for existence in some capacity is to help protect us. So think of pain as a gift, and it's telling us a story of what's going on inside of us. And the circuitry of pain, again, this is kind of a simplistic model, but hopefully you can kind of appreciate it. So we have nerves coming from our brain and our spinal cord out to our legs and arms and feet and all that. And there's a specific type of nerve called the nociceptors. With the nociceptors, they pick up temperature, pressure, and chemical changes. Now, when these nerves are stimulated, say again, putting your hand on a hot stove, the nociceptors pick up that change in temperature and send a signal to the brain saying, there is a change in temperature. It's hot. Now, the brain asks this question, is this a threat to me? Is this a threat to my tissue? So the brain kind of gets all this input and then makes a decision, either yes or no. If it's yes, there's a threat to my tissue, I'm going to cause pain so you can be conscious of what's going on and attend to that. If it's not a big deal, the brain is like, who cares? And it will just ignore that. This is kind of a hard concept in some capacity to conceptualize, but pain is an output of the brain. So just because these nociceptors are stimulated, like heat, warmth, pressure, all that, it doesn't necessarily mean it will cause pain. The brain makes a decision to cause pain or not. A brief, simple example is when you're like one day, hey, where did this big bruise come from? You obviously had tissue damage, but you didn't have pain. This is a fantastic example of what I'm talking about. In the 1995 British Medical Journal, there was this 29-year-old construction worker that was doing his job, and he stepped on a nail when he was just walking across the yard. And the nail went through his boot. So he could see the nail coming up through his sole, up through his shoe. And so he was in a lot of pain. He was like excruciating pain. They couldn't really touch him. And so they had to bring him to the hospital. So they loaded him up on morphine and pain medications, and it still didn't seem to help. The doctor eventually was able to get the boot off. And what they realized was that the nail went between his toes, not through it. And so there was no tissue damage. So he saw this nail through his shoe and he thought, it's through my foot. So as a result, the brain's like, I have pain now. But there's no issue. So just kind of sit with that how powerful our brain can be. So with that context, pain can be modulated. Runners have I could say stubborn, but very passionate about what they do. And a lot of people, I work at a company now that has a lot of young, relatively healthy people that love to run. And if they don't run, they get stressed. They don't know how to help with their anxiety. So it's a very important thing to them. So if their threat of running, or if they can't run, they get very anxious and stuff like that. And so the pain may be increased. And let me give you an example. A paper cut. You have a paper cut on a runner and a violinist. And they did the study too. Who do you think will have increased pain, the violinist or the runner? It's actually the violinist, because the violinist relies on their hands to play the violin. It could be their livelihood. So this is more important to them, where the cut on the finger for the runner doesn't really matter. So that pain perception is less. Even the better looking doctor, they've done studies with better looking professionals. Actually, the pain is better in the clients as well. So I joke with our colleagues, we should just hire a bunch of good looking people and the pain's away. So there's a lot of ways that pain can be modulated with how you perceive the pain. And I have pain all the time in some capacity, but I kind of understand it so it doesn't take over my life and understand how to address it. So if you're a running coach or even a runner yourself, learn how to talk to yourself or your clients about pain itself, that we have to calm the nervous system down and it's going to be okay. So to finally get to the definition of what pain is, and again, this is also a simplified version, but it's unpleasant sensory and emotional experience associated with actual or potential tissue damage. Again, note the potential tissue damage. So of course, pain is there when you hurt yourself with actual damage, but also potential tissue damage. So the main gist before going on is know that pain can be heavily influenced by how we perceive it. Pain comes on before actual tissue damage. The best way to illustrate this that I could think of is your hand over a flame. So you have a flame and you put your hand over it, and if you keep it there close enough, it will hurt. But if you take it away, it's okay. So just because you have pain doesn't mean that you have tissue damage from what was going on. So with a threshold, pain is there to protect, and it's there to warn you what's going on, and it doesn't necessarily mean that there's actual tissue damage going on. But please take that as a warning sign. Maybe you have to check your running form, your training program, your strength program, shoe wear, even get enough rest. So if the tissue stress exceeds the tissue's loading capacity, then tissue injury will occur. So for example, a lot of beginner runners have issues with overtraining or overloading because they go too hard, too fast, too soon. So there could be some tissue damage from overuse or straining of the tissue. So if it's actual tissue damage, there are 3 stages to look out for: inflammatory, reparative, and remodeling stage of healing. So if you're in the inflammatory stage of healing, it tends to be associated with higher pain. And it's usually the beginning of injury. So you get this redness and swelling, and on a pain scale, it tends to be above 6 out of 10. So if your client or yourself have an inflammatory condition going on, I say do not run. I ask this question to my clients to understand the pain. When the pain comes on, does it take a while to go away? Or is it there the next day? If it's yes to that, it's probably more inflammatory. So if the pain lingers, is also a sign of an inflammatory condition. The reparative phase, or phase 2, is mild, moderate pain. This can last for a few weeks, depending on the tissue or in the extent of the injury. And so usually at this phase, we can begin a run-walk program. And if you go to our website, it'll give you kind of a test to know before you run a run-walk program what to do. So in the reparative remodeling phase, the pain may take a minute or 2 to go away, but doesn't linger too long. It's not too high. So I tend to feel pretty comfortable going back to a run-walk program in this stage. The remodeling phase can take several weeks to months, but it's usually very low pain, less than 3 out of 10, and the pain goes away immediately once it comes on. So at this phase, I say, it's okay to run. And again, this is a relatively simple model. There are all nuances to every person, of course, but this is a kind of a general guideline that could help at least communicate with a runner, again, or yourself to think about when you're going through an injury. Just to give you an example of an inflammatory condition versus remodeling. On the left is a kind of red swelling example, and on the right, there's a nodule, and I've seen this many times. It's chronic Achilles issues. And what happens there is weakened tissue kind of clumped together, and it doesn't quite remold well. So it's a weakened tissue, but it's just very mild. It's hard, by the way. It's not soft. And that's more of a chronic tendinopathy. What also influences healing time is a tissue type. So I just want to point out this graph is on the left, or the y-axis going up and down, is the blood supply. And on the x-axis is healing time. So muscle tends to have a short healing time because it has a lot of blood flow. And as you go on the graph, all the way to our articular cartilage, it takes a little more healing time because of lack of blood flow. The main point here is that these phases are overlapping. So we don't fit cleanly in one or the other. It's a continuum. And sometimes you can go back into the inflammatory phase if you don't treat it right. So the stages of healing with tissue damage, this is the red light, yellow light, green light, and just kind of more of a summary of the last few slides. Red light, pain greater than 6 out of 10, easily aggravated, and pain is later in the day or the next morning. So that's a no-go. A yellow light is pain about 4 to 5. The pain can go away pretty quickly, but it still lingers a little bit. So I would do a run walk program. And for a green light, pain is not too bad and it's not progressive. And there's no lingering pain after you're done. Again, there's a little asterisk. Sometimes with chronic pain, if the pain still lingers for a while, I might just shut it down for a couple of weeks and then restart depending on their response to things. So let's go back to the runner that I described. He had 6 weeks left, and I talked to him for about actually an hour, understanding the stage of healing he was in. And he was kind of in the inflammatory reparative stage. So it wasn't a lot of pain, but it was enough to linger there. And I didn't feel comfortable with that. So I told him, hey, I don't want you to limp to the start line. And so the plan was for him is we held off for 2 weeks, and this is hard for runners, but what we had him do is go on a bike for a couple of weeks and then do a strengthening program and then reload until Boston. And I told him, don't do the sprints. Let's just focus on low intensity, long duration until you get to the race. And he did that. And he messaged me after that he had no pain during the run, and he actually PR'd. And I want the runners here knowing that just because you miss a few days doesn't necessarily mean that you're going to lose a lot of your training benefits too. I see a lot of stubborn runners, again, myself included, as clients, because we don't want to stop because we're going to think we lose our gains or we don't follow the program to the T. But I tell them that pain trumps the schedule, deal with the pain, and then we can get back on the schedule. Key points: pain over running schedule, what I just said. Most injuries I see from runners are overuse injuries. Too much, too soon, too fast. Training errors happen 3 to 4 weeks prior to injury. So you can run, you can race, you can do all that for a few weeks, and then it'll eventually catch up to you. So just keep that in mind, that because you might think the pain came out of nowhere, no, it just might have crept up on you over time, and now it can't handle much more. It needs rest, it needs a modification in your training program. General rules: pain should not linger after the run or the next day, so keep that in mind. To run, pain should be less than about 3 out of 10 on the pain scale. And if hurts when running, modify run by the distance, change the surface area, maybe to a track or something softer that's more shock absorbing, or walk run until the pain is under control. And if it really continues to get progressively worse or it's stubborn, I would suggest taking a week or 2 off, depending on the injury, and then we can reload the structure. And please respect the rest days. So what I do is, in my head, I think, is it contractile or non-contractile? Contractile is a muscle or tendon, and non-contractile is a joint, ligaments, stuff like that. So if I do range of motion, and then that's clear, it's passive, that's probably not the joint. If I contract the muscle, it hurts more with load, then I think, okay, it's probably a muscle or tendon that could be the issue. And so I explore that. And simply the location as well. That could be the easiest. Study an anatomy book. It hurts here, that's probably just the muscle because it's right on the muscle. It's a great question because we get this a lot. It's where the muscle attaches to the bone. So it's kind of in between. It's, I can make an argument for the tendon that attaches to it. So tendon attaches bone to muscle. So with that, it's just an overuse pretty much of the tendon, or if you want to get technical, the periosteal sleeve where the muscle inserts into, or the tendon does, gets irritated. So generally speaking, it's an overuse condition of that tissue with running.
As Eric said, there is a lot of subjectivity. Most commonly, shin splints are coming, from my experience in coaching, as a result of potentially actually 3 things. Like Eric mentioned, it could be a weakness, calves not being accustomed to the stress being placed on them, which kind of partners with maybe doing too much too soon. But then also, I find there's a commonality with some mechanics weaknesses, particularly in the arches, where the arches collapse and that stresses the bone and basically the tendon connection between the muscle and bone. That's a really common thing, which is related to a lot of foot mechanics or heel striking, or how the foot is striking in general. There's a lot of factors we can look at. So many injuries are related to running form in our experience. That's why we emphasize holistics, or strengthening of looking at all the joints, all the muscles, how they moving, how strong are they. That's a big factor. Then the load factor is another one. And once it gets to a certain point, as Eric suggested, there has to be more rehab and pulling off the stress, because shin splints are not an injury that can be run through at a certain point. There's early warnings where they can be with adjustment run through, but it takes a lot of diligence, but it can be done. I've done it for myself even a couple of times where I catch them a little early, usually from training intensity increasing and just the calves not recovering enough, so they're very tight, and that can start impacting it. So again, it's kind of a catch-all response, but it's because it's true. There's so much subjectivity to the individual's running background, running form, their training plan currently, and a few other things. And so that's where we like to ask a lot of follow-up questions to the specific person, because that helps us then hone in on a specific answer.